All right, super. So thanks so much for the introduction. Really appreciate the invitation as well. Just as Lisa was talking about, the public health trajectory isn't always particularly clear for physicians. I did actually try to get out of clinical medicine very early, like during medical school. But the dean, I guess, had seen cases like me and said, go do special studies, which meant stay in your subsidized New York City apartment on the med school campus and go figure out that there are even worse things to do than this, which is what I did. I went out and I did social work and realized that if we're going to look at how you use the dynamics of power to actually implement some sort of change and bring some sort of influence for what you might perceive to be the better, getting an MD is a great way to do it. And during that year of special studies, in which, as you can tell, I didn't study, but I learned a lot, did discover preventive medicine as an actual or specialty that I could pursue. So I just went straight through med school after that, did my residency at Hopkins, and then left the country in 2006 to go work for CDC through PEPFAR, the President's Emergency Plan for AIDS Relief. And I was first in Swaziland, which, if I'm guessing many of you might not have realized, they changed their name last year to Eswatini. So I was there, whatever the politically correct name for the country is at this point, and then was in Mozambique for the vast remainder of the time. I was in Mozambique for 8 years as the HIV prevention branch chief for CDC, and did not spend any time in Atlanta, which, depending on who you are and your perspective, being at CDC headquarters is either a great thing to achieve or something to avoid. And I'll just say I was happy being posted overseas. And we then decided to repatriate and landed in Colorado, where I had been once driving through in 1999. So it was, I would say, the reverse culture shock. Coming back to my own place where I'd grown up, my own country, was actually a lot tougher than going overseas. And it's probably because I thought I knew how things work. I was like, oh, I'm going home, go back to the US. I know that place. Turns out I really didn't. Colorado is very different. And also the public health terrain I'd become so accustomed to in Southern Africa and specific to HIV, it's just so radically different to what's happening here. And the presentation I'll get to today sort of demonstrates that. But I'll stop there in terms of my background. I don't have a ton of slides, so we should have plenty of time for discussion, questions, and I'll jump in. All right, so talking about HIV and hepatitis C outbreak vulnerability. Is the keyboard the only way to make this move?
Unfortunately, I believe it
All right,
is.
I can.
Scrolling.
Okay. Okay. So basically, we'll talk a bit about the background, why this even came to our attention, what's happening in terms of drug use and the opioid crisis. Demonstrate that connection between the opioid crisis and disease control, and talk a bit about the work that we've been doing and where we hope to go with it. Really just want to share with you some of what we've been doing. Want to make sure that it's clear to everyone who hears this, everyone I have a chance to speak with, that when we talk about opioid response, disease control is not second stage. It should be an integral part. When we're talking about reducing overdose deaths, we should also be talking about disease control. When we're talking about access to substance use disorder treatment, we should also be talking about disease control. And as Dr. Wheeler said, I'm sort of pressed into service in the last minute here. This slide set was actually directed at some local public health agencies. So the actions requested there, if you're like, I don't know what my jurisdiction is, right, disregard. If you do, however, have a jurisdiction, take this back and use it there. So, quick background. Let me see if I can actually get this. There we go. So quick background. So overall sustained increases in drug use, substance use disorder in Colorado, like in most of the nation. You'll note that what's actually represented here are overdose deaths. So you might be asking, if I just wanted to simply show you drug use is increasing, substance use disorder is increasing, why not just show you that? It's because we actually don't have good public health surveillance for substance use disorder, drug use, opioid use at the population level. So what we can track are overdose death rates, and that's the best proxy that we have. In terms of how that relates to disease control, in terms of the overall experience of drug use and substance use disorder, and this might, I can see might be a bit hard to see in the room here, but essentially it's a long path. There's a long history. Anybody who's experiencing substance use disorder, it didn't simply just occur out of nowhere, and there's lots of risks along the way. Sexual risk-taking behavior, for example, is something we're concerned about. We're seeing skyrocketing rates of bacterial STIs. What is the relationship between that and opioid use? That's something we're still exploring. But the point is really when we think about explosive outbreak of disease and things that make us worried, keep me up at night in terms of the public health perspective, it's really about the bloodborne pathogens, and it's really at that nexus of substance use disorder, opioid use, and injection drug use in particular. So that's where I'll be focusing today. So much like prevalence of drug use itself and substance use disorder itself, we don't have any population prevalence. We don't have public health surveillance for how many people in Colorado, what % of the population is injecting drugs. What we do have, the only data point we do have routinely is amongst those who are accessing treatment for substance use disorder, what do they report in terms of their route of administration, how much they might be injecting. And this is from our colleagues at the Colorado Department of Human Services. And as you can see for heroin, preferentially injected in Colorado, there may have been a slight decline, but doesn't look to be sustained, and that's a bit more than half injecting. That actually has a lot to do with the type of heroin that we see in Colorado. For a long time, essentially west of the Mississippi, based on drug trafficking routes, we see more black tar heroin than you see east of the Mississippi. So what you see in Colorado is not typically what you might expect or what you might have seen in the movies, for example. It's not white powder. And it doesn't necessarily lend itself to inhalational routes, snorting. It lends itself to smoking or injection, and you get a lot more bang for your buck through injecting. So heroin is preferentially injected. Prescription opioids honestly, I don't think you can even distinguish the line in there, but it hovers right around 10%. So about 10% of folks using and abusing prescription opioids are injecting. That's important because if you might recall from the prior slide, when we're looking at the overall increase in drug use, the proxy of overdose deaths, the single biggest contributor to that were prescription opioids. So even if a smaller fraction are injecting, it's a much bigger pool. And I'll come back to that point in a second. I did also include methamphetamine here, not literally an opioid. It's also on the prior slide as well. But really, we're putting a lot under that heading of opioid. It has to do a little bit with what is politically acceptable, what is culturally acceptable, and also how it aligns with our funding sources. It's being recorded, so I'll stop there. But methamphetamine is very important in terms of overall drug use epidemiology and in disease control considerations for Colorado, with about a third of folks injecting methamphetamine. So this topic, this concern of outbreak, the occurrence of outbreak related to drug use is not new. But there was a shift that happened in 2014, 2015 with a big HIV outbreak in Indiana. And this made national headlines. This was Scott County, Indiana. And this was, to my earlier point, this was not heroin. This was oxymorphone. This was a prescription pill being crushed, put into liquid, and injected, leading to this outbreak. And again, not exactly new. I put a few other headlines in there going back over some years, demonstrating the risk and occurrence of these kinds of outbreaks. But it was this HIV outbreak in Indiana that started to, I think, increase attention, increase salience and concern in public health communities around these kinds of outbreaks. And so CDC undertook the analysis of trying to predict where is the next Scott County, Indiana. What can we do for our states and our local jurisdictions to say, hey, this just happened. It's predictably going to happen again, and you in particular should really be very worried about it and start taking some preparatory steps. For example, in Indiana, it took a very, very long time to introduce the element of outbreak response related to providing sterile injection equipment, which of course is very helpful in reducing the onward transmission of bloodborne pathogens. So CDC thought if we can give some folks some heads up, say, look, this is actually relevant to you, start talking about it now so you'll have things in place. So they wanted to model this. As I've already told you, we don't have good public health surveillance data around drug use. We don't have good population-level public health surveillance data around injection drug use. So it's not as simple as just saying, let's show people the map of where injection drug use is happening and go deal with it. So CDC decided to use acute hepatitis C as a proxy for injection drug use. It makes sense. Acute hepatitis C has a fairly short incubation period, maybe around 6 weeks. It's a reportable condition. And the main way you get acute hepatitis C these days is through injection drug use. So then you might ask, well, in which case, why didn't CDC simply show us the map of acute hepatitis C and say this is where the problems are? It's because even though hepatitis C is a reportable condition, there's vast underreporting. 10, 15, 20 times actual cases out in the community, CDC estimates, as opposed to what's actually reported. And there are a few jurisdictions, a few states across the US where CDC has actually given those states specific funding for enhanced public health surveillance. So CDC had access to some good data, had big swaths of the country with limited data or inconsistent data or a whole bunch of zeros. So basically, CDC thought, okay, if we can at least match some sort of model to the curve of acute hepatitis C, then in those jurisdictions where they don't have good acute hepatitis C reporting, like Colorado, we can at least use these other indicators and figure out where we see risk with these kinds of outbreaks. So they did that exercise, and they came up with the list that you see here: higher drug overdose deaths, higher prescription opioid sales, lower per capita income, higher population white non-Hispanic, higher population unemployed, and higher buprenorphine prescribing potential. Buprenorphine is just one of the drugs used in medication-assisted treatment, and it's actually a fairly straightforward drug to use, but the reason CDC had access to this data point was that there's a phenomenally bureaucratic process to go through to use this drug for a long list of reasons we can talk about not right now. So they said, here's that model. You look at those indicators. If you score high where these things are happening, you've got acute hepatitis C, even if you're not measuring it directly, and you've got risk for this kind of injection drug use-driven outbreak. And CDC generated risk scores for all 3,000 whatever counties in the US, and then took the top 5th percentile, it's 220 counties. I don't think, obviously that math wasn't totally right, but nonetheless, they took the top 5% of all the counties in the US and said, these are the ones with the highest scores, this is where we have risk. And one county lit up, Colorado, and for those of you who don't have a priori knowledge, does anybody recognize, can anybody see, and if so, recognize what county that is? I don't think that's particularly helpful, but any guesses? I mean, it's not Denver.
They don't pass it.
It's close, but it's not.
Pueblo?
Ooh, what?
Was it Pueblo?
No, you would have thought, right? I would have thought, but you're getting into the right neighborhood now. It's Crowley County. Has anybody been to Crowley County? I keep meaning to go. So we thought, Crowley County, it's a rural county. It is economically, it's experiencing economic disruption. There's not a big population there, and it seems completely reasonable that Crowley County would have risk of this kind of outbreak. But it also seems really reasonable a lot of other counties would as well, like Pueblo, like El Paso, like, I don't know, anywhere else in Colorado. So it struck us as surprising. Then it wasn't in the manuscript, it wasn't in the published article, but when we talked to CDC, we also learned that Crowley County was actually number 220. So remember, it's that top list of the 220. It was actually dead last, barely made it onto the list at all. So we were like, okay, this was a great idea, CDC, but let's try to come up with something that's a bit more useful in terms of public health practice for Colorado. So we aimed to actually just simply replicate the CDC study. We simply wanted to use more current and complete local data, and we wanted to see a risk score for all 64 counties in the state. Sidebar, we couldn't use the actual statistical methodology that CDC used. We had a much smaller sample size. We had a lot more zeros with weaker reporting. And so we used something that is, I found, exquisitely complicated, called principal components regression. Our very own Brian McNair from university assisted with this, and he can answer questions. I still have questions. But nonetheless, we were able to use a different statistical methodology with help from the university to come up with the product we wanted. So we were able to generate this model. We were able to generate risk scores for all 64 counties. And what we actually found was leading the charge in our model were actually emergency department drug overdose visits. Turns out this is actually not an indicator that's available at the national level. So it's not like CDC put it in there and it didn't fit their model. They just didn't have access to it. That's not something that they could aggregate at that level, but turned out to be very important for us. Some of the other things that came up in our model were better aligned with what CDC had: prescription opioids dispensed, drug overdose hospitalizations, and unemployment rate. And here's the full list of all the statistically significant indicators that we had in our model. The bold underlined ones are just the biggest numbers that we'll see, but all of these were in the model. And I do just want to draw your attention to the first row and then about halfway down. If you recall, I mentioned CDC indicated one of their factors in their risk model was white, non-Hispanic. And we're actually seeing American Indian, Native Alaskan, and Hispanic white. So that to us was actually remarkably different from what we were seeing at the national level. And that was probably driven by very high scores, high risk in Appalachia, in the southeastern US, where there is segregation of populations and heavily white predominant communities. So in any case, we were able to take this, generate the risk scores. We used Jenks natural breaks to group. We had 14 counties with the highest risk tier, 10 below that, 18 in the middle, and then 13 plus 9 is 22. 22 lower. But I do want to be clear now, and I will say this several more times, we don't think there's any county in Colorado that is at no risk. And we didn't want either local public health agencies or community members or clinicians or public health professionals seeing this and thinking, oh, look, here's a county that's in the lowest risk tier. Excellent. We don't need to actually worry about this. We believe you still do. We think that there's no county that's really off the hook in these terms, but we do, of course, want to focus where we think the highest risk may be. So this is what the map looks like. Darkest blue is highest risk. You see some geographic clustering, sort of with the exception of Jackson County up north, down into the San Luis Valley, across the southern tier. And before going too much further, do want to be clear about limitations. Theoretical model, small sample sizes, and also always need to be cautious about reading too much into this. We asked a very narrow question, we got a very narrow answer. If you looked at that map, and I'll show you another map in a few minutes, but if you looked at that map and wondered, that county I thought might be at high risk like Boulder, it isn't. Is that because they have a robust syringe exchange program? Well, maybe, but we didn't aim, nor did we actually answer that question. So just want to be clear about that. What is a fair interpretation is the point I initially made. Disease control absolutely needs to be part of the conversation around response to drug use, injection drug use, the opioid crisis. And this is just a model that can be brought into those discussions and help make sure this topic gets some attention when we're talking about other responses as well. So in terms of what to do with this, okay, so fine, we've got some counties we see are at high risk. What are we going to do about it? So first, we're not exactly alone. This is a national discussion. There are a lot of other states doing similar adaptation. And there's two pillars. The first is really about treatment as prevention. Prevention, care, and treatment for hepatitis C and HIV amongst people who inject drugs. And there's information coming out from CDC. There's information coming out from the National Alliance of State and Territorial AIDS Directors, NASTAD. So there are resources we can use, but the idea is that we want to do better case finding, screening for HIV and hepatitis C amongst people with substance use disorder, amongst people who are injecting drugs, and provide outreach and linkage to care and access to treatment without restrictions. So the whole concept is decrease community viral load, reduce circulating virus, which therefore makes it more difficult for onward transmission, makes it less likely to have acquisition of HIV or hepatitis C. So that's the first approach. But of course, that needs to go hand in hand with getting just a little bit upstream and getting into that primary prevention space and preventing acquisition of HIV and viral hepatitis in the first place. And this really is largely about harm reduction and specifically increased access to sterile injection equipment. And this, of course, can be a difficult topic. There's a lot of different opinions around the concept of addiction, substance use disorder, what's culturally acceptable in any given community. In a home rule state like Colorado, it's extremely important to be respectful of that approach and really work things from the local level and see what's going to fit for a particular community. And so one thing I always like to make sure folks are aware of is that when we talk about harm reduction, when we talk about providing a service where we can collect used injection equipment, provide sterile injection equipment, there is a focus on the individual using drugs. There is a focus on that person who's injecting drugs, but it's really, there is this community level protective effect. Maybe we're talking about first responders and reducing risk of needle stick if they're, working with somebody and they have something in their pocket, reducing risk of that needle stick and contaminated equipment. And at the family level, picture, a married couple, two spouses, one who's experiencing substance use disorder is injecting drugs, the other spouse not in that situation, who may otherwise be at negligible, essentially zero risk, for example, of HIV acquisition, but now with the other spouse experiencing substance use disorder, that could come right into the household. So there is that broader perspective that I always like to raise. And beyond that, just in terms of potential next steps, of course, outbreak preparation and planning for response. So I did like, this is a synthesis statement that NASTAD had put together. It really is about increasing capacity of community coalitions, state health departments, and community-based organizations to implement effective primary infectious disease prevention programs and services tailored to persons who use drugs and have opioid use disorders. And again, very important to work this from the local level in Colorado and find what's going to fit. So I mentioned I'd show you another map. This is it. It's the same underlying risk map, but this time the red circles represent where we have counties that have approved syringe exchange programs. So the way it works in Colorado is that there's a state law that says syringe exchange is legal if the county commissioners approve it. So county by county we go. And these are the, I believe, 8 counties where we have, well, there's 7 on here right now. There's 8. Yeah, reading is fundamental, counting as well. So these are the 8 counties where we have syringe exchange approved. And this is good. This is progress. This is success. It also demonstrates there's a lot of room to grow. One is just in terms of the type of service delivery. So in some cases, the syringe exchange program is fairly narrow and focused. Like, that's what they do. They take in used equipment, dispose of it safely, and they give out sterile injection equipment. In other sites, we're seeing a more comprehensive approach, what CDC would call syringe services programs. And it's really about what I've been talking about through all the prior slides. It's about integrating that case finding, providing screening, testing for HIV, for hepatitis C, providing vaccination for hepatitis A and B, linkage to care, providing access to substance use disorder treatment, and so on and so forth. So there's room to grow in that regard. What's the actual program model that we're implementing, where we have syringe exchange in the state? And as you can see more plainly, there's a lot of room for geographic expansion as well, and trying to get counties that are at risk to approve and start implementing syringe exchange programs.
Okay.
Yeah, please.
How are counties funding that program?
Largely through CDPHE.
Okay.
So we have a few funding streams that we blend together. And if folks didn't hear the question, especially if there's anyone remote, so the question is, how do counties fund their syringe exchange programs? And the answer is there's CDPHE provides a lot of that funding, not all of it. So I'll talk about some of the other sources as well. So we do leverage federal funds. We do get grants from CDC and from HRSA, the Health Resources and Services Administration. And we can use some of those funds to support some related syringe exchange activities, but we are forbidden from using federal funds to actually purchase the relevant equipment, like needles. Cannot be purchased with federal funds. So then we leverage state funds. And luckily, we do have state funds available to us. We've got a few HIV-specific programs funded with state dollars, and we leverage those dollars to then procure that equipment, provide those needles and other sterile injection equipment. A few of the other sources are cobbled together either from local initiatives, DEA and others also have opioid crisis response funds. CDC has separate, grant monies that go to DHS and other organizations. So it's not only CDPHE, but we're providing a fair amount of support.
Do you know if these exchanges, if any of them were in response to some of this data, like the CDC data, or were these already kind of in process?
Great, thank you. The question is, were any of these syringe exchanges motivated? Were they stood up after this analysis, after this information emerged? The answer is no. The 8 counties shown here are all counties that had syringe exchange in place before we did this analysis. We are hoping that some of this information will help further the conversation. There are a few counties out there actively having these discussions with their county commissioners. Some of those discussions are going better than others. That's something else I think, if you want more info, we could talk a bit offline. It can be sensitive at the county level. The most recent one on here is Alamosa. They're the one that stood up their program most recently, and that was about 2 years ago, and more in response to just the overall increases in opioid use and injection drug use they were observing there.
Are these programs at a scale where they're sort of impacting the number of cases of at least acute hepatitis that you would expect to see versus what you're actually seeing?
Right, so that's such a good question. Thank you. The question is, do we have the saturation? Do we have the population level coverage of providing sterile injection equipment such that we're actually seeing public health impact? That was the question, right? Yeah. All right, super. That's a good enough question. I'm gonna let's wrap up the slides and then let's start with that one because that'll be a fun one to discuss. And actually, yeah, we're there, so good. Okay, so in summary, disease control, a key topic as part of any discussion response. And I think most importantly for wrapping this up, do want to acknowledge other team members, Brian here at the university, as well as Alexis and Allison at CDPHE, who really did a lot of the heavy lifting on this analysis, and much appreciation to them. So let's start with that first question, and then we'll open it up to broader discussion and other questions. So in terms of population level impact, it's very different for HIV and for hepatitis C. And we really have done very little tracking on hepatitis B, although we're concerned about that as well. And even though you might think of hepatitis A as largely a fecal-oral route, there is a role for injection drug use in hepatitis A as well. And if you're not aware, we're having a current outbreak, along with a few other states, but Colorado has a current outbreak of hepatitis A amongst people who are experiencing homelessness and substance use disorder. So in terms of that population level needed, for HIV, it's pretty straightforward. If we can get folks to use sterile injection equipment for, let's say, the majority of their injections, we're probably going to reduce significantly HIV transmission and acquisition. HIV is not nearly as transmissible as hepatitis C, and we don't need to be perfect with our syringe exchange to see that population level impact. We have not yet seen any spike in HIV related to injection drug use. We're tracking it closely. We follow those numbers, and we see little blips that tend to go away, so we're definitely worried about it. But so far, we think that the syringe exchange programs are having effect. And the only reason that we're not necessarily seeing increases in HIV in a place like, I don't know, maybe Los Animas, right down here, is probably that HIV spark hasn't been introduced. So CDC, I didn't go into this part, but in the CDC paper, they actually did an HIV proximity analysis. They didn't actually end up combining those two models. So the risk model they generated, the one that showed Crowley, was really just based on the indicators they used for the model and the risk score. But they had done this fancy footwork where they looked at this 20-mile radius, kerneled around each county line to see how much HIV was around there. But it was really hard to draw any conclusions, and they didn't end up drawing any conclusions. And so all we did for that step, we simply looked at our risk map and looked at our HIV prevalence map, and we were like, okay, cool, at least there's not huge overlap right now, because it's that spark of introducing HIV into that network. That's probably what happened in Scott County, Indiana. There was a long-standing network of injection drug use. There was full saturation of hepatitis C in that network, and then that HIV spark was introduced, outbreak. And the reason I can tell you that is some other super bright folks at CDC used a hepatitis C phylogenetic analysis to demonstrate that HIV followed the same transmission routes that hepatitis C had followed in that same network. But the pre-existing prevalence of hepatitis C in that network was already 60, 70%. It had already saturated through there. So to talk about the hepatitis C side of prevention through syringe exchange, it's really, really hard. The evidence base for preventing HIV through syringe exchange is robust. The evidence base for preventing hepatitis C through syringe exchange, you've got to jump through some serious hoops. And those hoops include very early access. Like, you might acquire hepatitis C the first time you inject. And so we need to set up systems where access to sterile injection equipment is saturated in the community in such a way that that's just the norm. And we're not there. We also, hepatitis C has that level of infectivity where you really need to be using sterile injection equipment each and every time you inject. And then the final component of this is that actually the type of syringe is very important as well. So there are some syringes that have more versus less, dead space, where when you depress the plunger all the way, some of those syringes are designed that 100% of the contents, the barrel, is fully evacuated. Others of the syringes will leave a little bit remaining there. You can never fully evacuate that barrel, that syringe, just by depressing the plunger. And so if we're talking about HIV, and again, HIV, we should consider it highly transmissible, but hepatitis C is at least 10 times more. And so when you have that little bit of remainder blood in the barrel, and hepatitis C has wonderful survivability in the environment, also a bit different from HIV in that regard, or significantly different, then we start to worry about that as well. So you need a really good, locked-in, comprehensive, firing on all cylinders syringe exchange program to really impact hepatitis C. It appears that the secret to making syringe exchange work for hepatitis C is actually combining it with medication-assisted therapy. That might sound a little strange because I think many people consider those to be, sort of binary. Like you either are injecting and you should use sterile equipment, or you're getting treated for your substance use disorder. But what actually happens in a lot of cases, you offer medication-assisted treatment. You're on opioid substitution therapy, and you reduce the frequency of injection. So that combined with access to sterile equipment seems to be working well. And those are a lot of studies coming out of Europe where they're quite a bit further down the road in terms of having programs that offer both MAT and syringe exchange. Great question, thank you. Other discussion points or questions?
Anybody else? Go ahead, you
Yeah,
go.
I'm curious about looking outside the borders of Colorado here. And surrounding states' policies, or you mentioned, roughly looking at where the areas of high risk are within Colorado. Did you also look around the border to assess the risk for a spark, as you were saying?
We did. It was actually, we thought that was going to be very straightforward. We thought we'd be able to pull up the neighboring states' county-level maps for HIV prevalence. Turned out to be pretty difficult. So we did sort of reach out just more on an individual basis to states to really try to assess that. We didn't find any red flag, smoking gun, like, oh my goodness, this is it's there. We need to go drive down and talk to these folks. So we did do that analysis. We also tried to look at neighboring states just in terms of what their coverage for syringe exchange looks like, because that was something we did try to put into the model. That was a bit more difficult. New Mexico is really, they have a solid approach to syringe exchange. They have a fairly robust network. A lot of people, the San Luis Valley, if you've been down there, there's no natural barrier north to south. The valley, you've got barriers to the west and the east, but for folks who are living down there, you drive into New Mexico, it's just part of the same terrain where you live. And so we do believe folks are crossing the border to the south to access syringes. So did that have some sort of unknown impact on our risk model? We're not sure. But then, of course, some of the other neighboring states, they don't have that same perspective on syringe exchange, nor that same openness to it. And I don't think that's a great answer to your question, but that's what I got.
Well, I guess more of a policy question. So there's been a lot of talk in the news about the money potentially coming from Purdue and the attorneys general working on this negotiated settlement, and just wondering where public health is in this conversation, and if there is a conversation about how much or how much you might need to really support implementing syringe exchange or other programs that are needed for public health. I just haven't heard the public health side of that conversation.
Yeah, thank you. So the question is around the seat public health has at the table, the influence we have on the agenda when we're talking especially about resource allocation. And if I'm asserting that disease control needs to be part of these discussions, well, the question is it? I believe. So that's first of all why you see that message, or it's intended to shine through. The message is let's talk about disease control, because that typically has not been part of the discussion. We're seeing small slivers, 5, 7, 8% of a massive MAT grant, medication-assisted treatment grant, for example, that might pay attention to some disease control issues. So that's something, but that's still a pretty small sliver. When it comes to these ongoing discussions in terms of is there going to be a windfall payment similar to what happened with big tobacco companies in decades past, and what of that is going to go towards public health, I would first just want to be clear, the actual opioid response, right? Access to treatment, looking at adverse childhood events, reducing risk, reducing folks who experience substance use disorder, that is core public health as well. Of course, my little section of public health is around the disease control. So there's a lot of public health here, but specific to that disease control element, this is where we're trying to get, right? We do want to make sure that when the time comes, folks are aware this is an actual issue. I would say that awareness, however, is only part of the problem. I think there are significant issues around cultural acceptability. So the idea that you can conceptualize substance use disorder as a disease and not as a moral shortcoming has made, it's gotten some traction. Not everywhere with everybody, but there is a different perspective. For those of you who follow, various social justice narratives, the idea that the last time we had a big crisis like this, we put everyone in jail, and this time we decided to treat them as folks who had brain disease. Well, there's a racial ethnic dynamic to that as well. But nonetheless, progress is progress, and we do see a lot of legislators and policymakers really thinking about these people as humans, not just as people who simply chose to become addicts and deserve to die. So that's great progress. When it comes to the disease control side of things, there's not exactly that same thing. When we talk to law enforcement, for example, they might say, I had that epiphany. I always thought to myself, these are druggy addicts, and I never saw them as people. And then somebody helped me make that connection between alcoholism and opioid substance use disorder. And I realized all the people I know, even in my own family, folks who are alcoholics, they never intended to become alcoholics when they took that first drink. And so now I understand these folks never intended to become people with substance use disorder. So okay, I get it. I'm law enforcement. Historically, we haven't been too kind or receptive of, folks along these lines. But now I get it. We're going to do that. But I'm not going to give a criminal a gun to hurt themselves. So I'm not going to give them the syringe to do this. That's a bar too high. So we still have that. There's still an acceptability barrier. There's a communication barrier. We are doing some surveys with county commissioners, law enforcement, other stakeholders to find out what they know and understand around harm reduction, including syringe exchange, and we're hoping maybe we can craft some new messages that will resonate. We did recently do a general population survey. It was an internet panel, and these are preliminary results, but what it showed essentially was when we asked the question along the lines of, if syringe exchange were effective in reducing the spread of disease in your community, would you support it? 75% yes. Then when you ask the question, should syringe exchange be legal in your community? 50% maybe. And when you ask, are syringe exchange programs legal in Colorado? 40%. So there's a knowledge gap, there's a perception gap, there's an I don't know exactly how we're going to get over it gap, but we're oriented towards it.
I had a question regarding IV use in prescription opioids. So within the past 5 or 6 years, most of the prescription opioids, they've worked on becoming tamper resistant, right? In the sense where pharmaceutical companies are trying to prevent diversion of IV drug use. Is there any data supporting that has decreased the use, or is it very limited in terms of any outcomes?
Thanks. So the question is around whether efforts in the pharmaceutical industry to make opioids more tamper-resistant have been effective. Is that? Yeah. So no, I don't think so. I don't think the tamper-resistant efforts have had any significant effect. For those of you who have, worked in the the hospital, using Pyxis systems. Those are technically tamper-proof, yet you can get fentanyl out of them and divert it. Likewise, if we're talking about Suboxone, which is a combination drug that has both the buprenorphine I mentioned earlier, along with naloxone, one of the pharmaceutical companies had the good idea, it's a good idea, to make this film where it's combined. So you can't, basically have to take the drugs together. And, we're in an innovative country, and somebody figured out how to separate that so you can just get the buprenorphine without the naloxone. So I don't think that has had any significant impact. What has had, I believe, a major impact is actually decreased access to prescription opioids. So there's a prescription drug monitoring program in Colorado and in many other states. Physicians who seem to be prescribing high volumes of opioids might get a visit from the DEA or some notice from the medical board. Restrictions along those lines seem to make sense. They also push people towards heroin, right? So withdrawal from opioids won't kill you like alcohol. It's not actually life-threatening, but you believe, you really feel like you will die. When you hear folks talking about being dope sick, like I'm sick, I need some, they really do. So when that supply gets cut off, when your physician has these restrictions on prescribing, we are actually seeing prescription opioid use go down. We believe there's been an uptick in heroin and potentially other drugs as well. So that's, to answer your question, that might have been effective, but also may have had some unintended consequences.
I always think of opioids, the opioid epidemic as sort of a pattern of, well, there are a lot of prescription opioids, and now those are less available. People are moving to heroin, fentanyl, that's more available. So it seems like if you make the prescription opioids less available, then you might have a stable pool of people who are already using fentanyl or heroin, but you sort of decrease the new instance of new people using opioid. Has that been seen? Is there any, or is that just a mischaracterization of what's actually going on with it?
No, I think that's completely reasonable. The question is around whether or not there is the intended consequence of reducing access to prescription opioids, such that we don't have as much initiation or onset of substance use disorder and addiction. So yes, I do think that's probably true, right? So that component may be effective. I don't have any data points that would show that yet. But it certainly intuitively makes sense, right? All the cases you hear about, I got into a car accident, I got in the hospital, the doctor prescribed this stuff, and then 6 months later, I realized I couldn't stop it. Yeah, this should help. But there is still that corollary effect. So if we're looking at public health policy, and trying to look at it comprehensively, it would be great if we could make progress in parallel, as opposed to having these kinds of trade-offs. And was that your question?
Yeah.
There you go. I probably should have checked before I answered.
That's such great questions.
Yeah.
So I'm sure you've shared this with CDC, right? Your state-based model, which seems to have some very different results than their model did. I wonder if there was a discussion about that, or if they would rethink how they did this next time, considering that there really often are these better data sources locally, and you can really get some misleading information, despite the good intentions there.
Yeah, so the question is around how CDC has looked at our findings as different and pointing in a different direction from what their model revealed. I would not say, when we're talking about mathematical models, I wouldn't say anything's misleading, right? The idea is they're all wrong. They're all wrong. Ours is wrong too. CDC's is wrong, right? It just, what it does is it helps move the conversation. It helps us think through where we might be seeing risk and what we might be able to do about it. So there's a handful of other states, maybe 10 at this point, who have done similar adaptations. I think the main lesson that CDC has drawn is that their methodology was much too complicated. Our methodology was even more complicated because we started from CDC. We were one of the first states to try to replicate this. And we were trying to be very literal. We wanted to replicate it. We couldn't. So we did something even fancier with even more complicated statistics. Other states are taking a huge step back from that. And they're seeing some of the difficulties in both conducting the exercise and interpreting the results and saying, what if we just radically simplify this? And what if we just simply take something very straightforward like ED visits? Like, that's good enough. You know, if we have ED visits for overdose deaths, seems safe to assume there's drug use in that community. And unless we have evidence to the contrary, seems safe to assume some fraction of those folks are injecting drugs. So Washington and Oregon, they sort of picked this up maybe 6 months after we did. And I'm slightly jealous because they have realized, like, you guys worked on that for 6 months, and maybe here's a simpler way. So, yeah, good for you. I agree with them.
No other questions. Thank you so
Thank
much.
you.
Fascinating talk, and I hope people enjoyed the talk and the discussion. So thank you very much.
Yeah, thank you. Great questions. Thanks.